Good morning, Professor Memet Ozek. I am very happy to meet you in Istanbul, and thank you very much for all experts medical patients for such a good results of the surgery. We know that you are one of the best neurosurgeons worldwide for pediatric neurosurgery and for rhizotomy. So I would like to ask you some questions about that.
Sure.
First of all, regarding the brain biopsy, the brain tumor biopsy, many of our patients are worried that the brain tumor resection and brain biopsy can cause some spread of the cancer on the body. Is it a myth or it is a truth?
So our approach to brain tumors is on that way. We are not asking for a biopsy from every tumor. We can separate brain tumors into two major groups. One, the expanding tumor, which just pushes the normal structures away. The second group is the so-called diffuse one, where the tumor cells are infiltrating all the eloquent areas of the brain. In the first group, wherever the tumor is, even with the brainstem, thalamus, hypothalamus, our main policy is to take the tumor out, because this is the only way to save the life of the patient. And of course, the MR technology has developed enormously so that our neuroradiologists can diagnose precisely, maybe 98%, they give us the correct pathological diagnosis just with the MRI. So if we have the information, this is a resective tumor, you can save the life and you can achieve a good resection, then we do the tumor surgery. If you know how to do it, you can remove a tumor from every part of the brain. If it comes to the diffuse tumors, some of them, like diffuse intrinsic pontine glioma, this is the famous one. This is not a resective pathology, because you can never take the whole tumor out. If you would like to achieve a total removal, you have to take the brain out, and then the patient has no chance to survive. So on those patients, we ask for a stereotactic biopsy. Again, if you use the computer well, a stereotactic biopsy has a complication rate of just 1%.
Mm-hmm.
Why are we taking biopsies? In old days, maybe till last 10 years, we didn't take biopsy from DIPG, which is diffuse intrinsic pontine glioma. We didn't take biopsy. Why? Because we know the name of the tumor and we know the prognosis, which is unfortunately very bad.
Mm-hmm.
Overall survival is around 9 to 12 months. And even my teacher was saying, these poor kids, they have little time, short time to live. Why to put them into stress of a surgery? But especially during last 5 years, there were a lot of developments in molecular biology. Now we are asking for the genetic material of the tumor. Why is that so important? Because there are now very recent developed chemotherapy agents, which is called as targeted chemotherapy. Therefore, you need the genetic information of the tumor in order to give a chance to the patient. Now we have brainstem, diffuse brainstem tumors who are still alive after 3-4 years. Of course, I don't know for how long they will live, but at least compared with the statistics, we give them 2-3 more years to live in good, normal conditions. Therefore, the family does not need to hesitate from a stereotactic biopsy.
Mm-hmm.
Of course, it's a surgical procedure, but the complication rate is 1%. Till now, we did more than 300. We never had a bleeding. But, I mean, you need to pay attention on this procedure. If you think, oh, it's just a biopsy, very easy, this is not correct. So we have our MRI pictures and we calculate on them with the computer to find out the safest way to reach the tumor. Because what you are doing is you are practically putting a very thin needle through the brain till you get to the target. So you have to find out the appropriate way to reach to the lesion. Then it's very easy because everything is calculated with the computer. So there is no chance to make a mistake.
What equipment do you use to make this surgery, the tumor removal, more safe and more efficient?
Okay. Number one, you need knowledge, so you have to learn. You should know good anatomy. But of course, there are important technical, let's say, yes, equipments to help you preoperatively, during surgery, at the end of the surgery. Preoperatively, again, it comes to a good MRI evaluation. Most of the people think, I will see the MRI, this is the tumor. Yes, everybody sees the tumor. You need additional information. From which part this tumor gets the blood? Which structures are pushed to which direction? Because if you look to a routine MRI picture, you don't see the so-called tracts in the brain. Tract is the way between different parts where the information goes from one point to the other point. So right now there are some sequences of MRI where you can see corticospinal tract, which means I want to move my fingers, okay? Here is the center. It goes down through the brain, through the spinal cord to my hand, right? Now, on a routine MRI, I don't see from where they are running down, okay? Now, if you have a tumor, it shifts these fibers to which direction? According to this, I will decide for a safe entry. For example, there is a sequence called DTI. This shows us where the fibers are. Mm-hmm. This is very important, so you don't make harm to the patient. Second thing, of course, it's a microsurgery, so we need a good microscope. We also use endoscopes for that. After removal, you can, or let's say that way, after the surgeon thinks I remove the tumor, you have to control what you have achieved. Good. We have right now 3 things in our hands. Number one, you put an endoscope in and you look around with the endoscope, because with the tip of the endoscope you have a much precise view about the anatomy. Number two, we are using intraoperative MRI now the last 16 years, 3 Tesla MRI. That means you think I did a good job. Before closing, before finishing the surgery, we just shift to the patient to the MRI, which is in the operating room, and we see what we have achieved. And to be honest, although we think we are experienced, sometimes we see, oh, there is still a small piece somewhere at the corner. So you continue with the surgery and you remove the last piece, which will be very effective for the life of the patient. And then a third thing, what we are now using for certain tumors, not for every tumor, intraoperative stainings. Now, for example, the simple one is fluorescein, okay? Before you attack the tumor, okay, you give a contrast material, fluorescein, to the patient. And if you have a very high quality microscope, you change the view of the microscope and you see the tumor, for example, yellow. So you remove the yellow part. Or again, you are not sure, is this part down there tumor or normal brain, for example. You change the filter of the microscope, again to fluorescein, and you see, oh, it's yellow, it's tumor. So you can continue. This is also good equipment. And plus, for not doing harm to the patient, we are also using intraoperative monitoring. Of course, this is not the job of the neurosurgeon. We have a dedicated team from neurology department for that. So before we start with the surgery, they put certain electrodes here on the skin and also on the lower extremities. And when we do a surgery, and for example, again, the same example with the hand, it's a tumor which is very close to the center of hand movement. So they can alert us. Stop, you are very close to the center of the hand, be careful. If you continue, the patient will be not able to use his hand after surgery. So it's an additional support for us. But again, I'm coming back to the beginning. You may have all these equipments, but if you don't know how to make the surgery, the system, the technology is not able to do the surgery for you.
Yeah. And many of them
Nasıl?
frozen surgeries.
Okay. Also, we are a lucky department on that sense because we have our neuropathologist always with the team. Her room is just here, 5 meters after my room. She's always with us in the operating room. And we have a small pathology lab in the operating room. So when I see the tumor, I just take a small piece, I give it to the neuropathologist, and within 5 minutes I get the result. This is also very important. Why? Right now, especially in pediatric neurosurgery, we have certain tumors. They are so-called germ cell tumors. Right now, there are very effective chemotherapies to kill the germ cell tumor. So, if you have a biopsy before you start with the removal of the tumor, and the neuropathologist gives you the answer, it's a germ cell tumor. Statistically, you don't need to remove all the tumor because at the moment you start with the chemotherapy, the tumor disappears. So you just need to debulk the tumor. If the tumor creates a compression, of course, we have to take some part out, but not till the last drop. Therefore, the frozen section information is very important for the strategy of your surgery. So there are different factors which helps you for your decision making and the continuation of your surgery.
Maybe it's a bit different question, but many of our patients are worried that when you remove the tumor, you separate the tumor cells, and some of these tumor cells can go to the blood flow and can cause the spread of the tumor. I just want to ask you to say that it is not true because
this is not true with the brain. This is not true with the brain. And before, this is detail, but before I remove a tumor, I always interrupt the blood supply of the tumor before, so that we are not losing too much blood during our surgery. Let's say you are operating on a child who is just 5 kilograms. This child has only 400 milliliters blood, like a Coca-Cola can. It's not like an adult. If you lose, let's say, half liter of blood, on me, on you, it's not a big deal. You even don't need to make a transfusion. But this is the whole blood of a child. Therefore, our strategy is always clip or coagulate the blood vessels which are bringing blood to the tumor. Tumor needs blood, needs to eat, to grow. So, therefore, there is no chance that one of the cells goes into the vessel and goes somewhere. This does not happen.